好，各位长官、各位贵宾、大家好。Morning. Because we are expecting fewer audiences today, we don't know for sure. I was told to tell everyone to please move up. Take these seats. See better, interact better. 我们卫福部的长官是说，我们请各位贵宾，请大家往前坐，先把前面坐满，这样子。好，谢谢各位。And in addition, our VIP delegates, you do not have to queue up with everyone for the refreshments, coffee, drinks. You have the choice of going to second floor, a closed room for you to enjoy. Better? Much better. Doesn't matter. Still better. There's a difference. There's a difference. Yes. But you have to take the elevator. Yes, by the time you queue up, you're gone. I think, thank you.各位贵宾，也跟您报告一下，今天如果要 Q&A 的话，您要发问题的话，请来到前面这边发问题。主办单位非常贴心，安排了1个立架麦、2个立架麦、3个立架麦，给您发问题。所以如果您要发问题的话，就请来这边发问题，谢谢。Okay, ladies and gentlemen, 我们国内国外的都要听到。如果您没有扫 QR code 的话，就等于您今天没有报到啊。你人来了，但是我们系统里面不知道。So, ladies and gentlemen, you must scan the QR code in order to register today. So maybe you're here physically, but if you didn't scan the QR code on your badge, the system doesn't know that you're here. It would count you as absent.好，各位与会的嘉宾，我们今天一样也是有同步口译的服务。您可以在我们报道处凭您有照片的证件来换取 TICC 的同步口译的耳机。那楼上的口译老师的讲的话，您就可以听得见了。一中二英 ，Channel 1 中文 ，Channel 2英文。So we are providing simultaneous interpretation service for you today as well. The headsets are available right outside. Okay, ladies and gentlemen, by the power vested in me by our moderator, Professor Lai, I'm told to tell everyone that we shall start in 3 minutes. We shall be waiting for more audiences to arrive, and then we shall start at exactly 3 minutes past 9. So good morning, ladies and gentlemen. Welcome to day 2 of 2019 Global Health Forum here in Taiwan. Our theme, once again, is urban life in the 21st century. Yesterday, we talked about the urban environment. Today, we will be focusing on urban health. And to do that, let me welcome our moderator to introduce our speakers. She is Professor Chonghui Lai. Professor Lai is the professor and vice superintendent at Chang'an Memorial Hospital at Linko branch. And Professor Lai also teaches at Chang'an University College of Medicine. She's rising to her position right now as we speak. Professor Lai, good morning.
Good morning, distinguished guests, dear ladies and gentlemen. I think everybody have enjoyed a wonderful meeting yesterday and a fantastic performance last night and during the daytime opening ceremony. And today we're going to talk about more on the urban health. The first speaker, Professor Yingwei Wang, he graduated from National Taiwan University School of Medicine, and he received PhD degree of Public Health Tropical Medicine, Tulane University. Currently, he served as the Director General of Health Promotion Administration, Ministry of Health and Welfare, Taiwan. He also is Associate Professor of the Department of Medical Humanity, Zhiji University, Taiwan. He had before his current position, he was devoted in community health promotion, elderly community care, mobile medical services, and community care for remote area. On top of promoting primary health care, he also emphasized on the promotion of health in workplace, school, and cities. Today, his topic is role of SDG, universal health coverage to address future urban health challenge. Let's give Professor Wong a big hand.
Thanks for the introduction by Professor Nai. I think this is the first time she introduced me because we are good friends. We know her about 40 years. And he never used this introduction for me. So let's talk about the topic today. Actually, I changed my slide almost 80% because many of my slides was presented by many of the speakers yesterday. And I hope that I can share some of the experience in Taiwan that what we have done in the past. So start from this slide that we notice from urbanization, we know there are a lot of changes. Sometimes we need to understand about SDGs, globalizations, migration, urbanization, climate change, aging, multi-morbidities, NCD, technologies. These terms I'm going to focus on a part of a few of these terms in my presentation. First, let's talk about SDG and urbanization and climate change because I think that's I think most of the audience are quite understand about these terms, but some of the audience are just maybe new to these terms. First, we notice that SDGs start with the MDG. It's the Millennium Development Goals that start from UN to year 2000. It covers 8 domains, including that in the 8 domains, there's only 3 about health. But they found that the population trend is getting older and older, and fertility decline, aging, migration, and urbanization is the development. And economic and poverty, eradication, globalization, and trade are the major concern in the new era. So because of the changes of the generation, they start with from 2015 and then changed to the SDG. And now there is 17 steps about that of the SDG. And in these 17 goals, we can divide it into the people, the planet, the prosperities, and the peace and partnership in the 4 major domains, from goal 1, goal 2, goal 3. And we noticed that in goal 3 is good health and well-being, but actually, health is related to most of the goal. You notice that as goal, health is the goal 3, but 1 is to end poverty and ensure inclusive educations, gender equalities, and also about the cities and also climate change are close related with the health. So 70 goals, not only the goal 3 is about the health, but the other goals are related with the health. And how about the health system and UHC? Universal health coverage. We start with the health system strengthening, and then there's goal 3 and 3.8 in goal 3. There is the universal health coverage. And there is, as I mentioned in the previous slide, that about the different goals related to the universal health coverage. So what is a universal health coverage? Just a brief description about that. It's about the population. We want to expand our population. We expand our service and decrease about the cost. And that is the universal coverage in the 3 dimensions. So from the topic show, you notice that there's 2 parts of it. One is the service coverage. The other is financial protection. It included about these 4 major domains is the reproductive, maternal, newborn, child health, infectious disease, non-communicable disease, and service capacity. And each with the 4 subtitles, including family planning and antenatal care. What is the position in Taiwan? We are allowed there's a score about UHC. The score is more than 80. It's a good performance. Taiwan number 85, so it's quite good. And I used enough time to change the color because the color is same from the website, but our color is different. It's similar to the highest portion. So how about the urbanization? We just learned about the terms about SDG, the terms about the UHC, and urbanization. There's a lot of problem or effects on urbanization. The one is overpopulation. The second is about the joint families, the change of the family into the nuclear families. And also the interpersonal relationship changes. And a lot of, because people are more focused on themselves or their own self-center. And the problem of pollution that some of the speakers presented yesterday, and also the stress and a lot of problems during the urbanization. And yesterday, I think I was speaking morning, or someone who said that there's a health inequality because this is a report by Momo. We do the same report 5 years ago because it is reported by WHO, and we do the same statistics in Taiwan. We are allowed in the Taipei 101, just in Taipei City, and this is the remote county, just like Hualien or Taitung. This is most of about 1/3 of people are Aboriginal. We noticed that the life expectancy is different. Yesterday, one of the speakers mentioned that why we live in Taipei is have a longer life expectancy than the people living in the remote area. I think for the elderly population is almost the same, but it is related to some of the early mortality for the infant and children and the adult. And also that the report from Lancet about the climate change, and this, as we noticed that there are a lot of cascade changes from the climate change, including the greenhouse gas emissions, and also in the ocean acidification and other pollutions, including the flood, heat wave, drought, and fire. There are a lot of, and then they're calling about the health, about the undernutrition's impact on mental health, and also the cardiovascular disease, respiratory disease. There are a lot of disease related. The source of this disease is about the gas emission. So from WHO, they said, what is the urbanization and health? What can the cities do to meet the changes? They said we have to change the health behaviors. We have to improve the urban living conditions, and also the cities are accessible and age-friendly. So they mentioned about the life course. The life course approach to health. Also, yesterday, we have mentioned about the intrinsic capacity. As we noticed that as we're getting older and older, the intrinsic capacity slowly, gradually decline. But we hope that the functional capacity, abilities, do not decline as the intrinsic capacity. So the life stage, and including the social and environmental determinants of health, is very important. This is why we are target on the rights of the people. So this is from the birth and later childhood, young and older adults, in the healthcare needs, health system, and also the environment. When we're looking at this one, let's look at the profile in Taiwan. This is the most recent profile. We have 23.5 million people, and age people over 65 years old, about 40, now almost 15%. And now the total fertility rate is 1.06. It's quite low, maybe the lowest among the globally. And the life expectancy is about 80 years old. So we start the life course approach from Taiwan that in different settings, from the birth, school age, and down, and using the ecologic model that including individuals, the families, the workplace, and the cities. Including that, we hope that we can empower people and engagement, empowerment and engagement for the people that they can engage with the care for themselves. And also we emphasize on the public, private, and partnership. This is the start from maternal and child health until the, and also including about the health literacy. This is the program that, that the Health Promotion Administration target from baby-friendly initiative hospitals, health promoting schools, health promoting workplace, age-friendly cities, and also the health promoting hospitals, and also health promoting community binding. And also we have a healthy city program from the fetus to the elderly. So this is the urbanization in Taiwan. I think some people come to Taiwan notice that there are so many motorcycles, and also there's a very traffic jam. So how we do it? We encourage to use the electronic motorcycle, not only to use the official motorcycle. We also use the electronic public transportation. But I think maybe we can encourage the more just using the bike, or even better, we use the walking is better than the bike, or better than the electronic motorcycle. So this is the co-benefit of the program: benefit for your health, benefit for the planet, and benefit for your pocket. Just walking. So I walk to my office every morning if there's no raining or there's no conference. This save the money and improve my health. And also, we promote about the plant-based diet. We promote My Planet. My Planet, there is a slogan and calling that each day you have day and night have a cup of milk and the fruit. And for the meat, use the bean is better than the fish is better than the egg is better than the meat. So this is all somewhat related to the concept of the plant-based diet. Maybe you noticed this, the gentleman yesterday, that the Pokemon, actually, Professor Chen just sent a message to me that Pokemon is encourage people to go around to exercise, to walking. This is a true picture that so many people to find the Pokemon walking. And this old gentleman using many cell phones to pick up the Pokemon. So very encouragement. And how about this one? This is from 10 o'clock yesterday, Taipei 101. And we noticed that actually we are from the religion in Taiwan that we have used a lot of incense for praying. But now in Taipei, there's a low burning incense temple. Even we worship for the ancestor is online. We're just praying. We do not burn it, but we're using the true incense. So let's talk about NCD. Also, this is a major leading cause of death in Taiwan, and also the technologies. If you notice NCD, there are a lot of related with different goals. I mentioned about health, and now we focus on the NCD disease target. NCD including the cardiovascular disease, the cancer, respiratory disease, and diabetes. And you notice that the goal 11 is about the livable cities, inequalities, economic growth, gender. All these are closely related. So there are 4 risk factors for the NCD, including the tobacco use, unhealthy diet, physical activities, and harmful use of alcohol. As you noted, just in my previous slide, WHO encouraged about the behavior change. But now there's the 5th risk factor, is about the air pollution, PM 2.5. There's another risk factor related with all the diseases. This is the present situation in Taiwan. The leading cause of death is cancer, and then there's heart disease, pneumonia, and diabetes. And we are talking about NCD. We use the so-called chronic care model, because as a chronic care, most of the NCD are chronic disease. The chronic care model, including the community's health system, inform active patients, and prepare proactive practice team. So how about the informed active patient and about the self-management support? Yesterday, one of the audience asking about the health literacy. We noticed in Shanghai 2016, there is the 9th Global Conference of Health Promotion about the good governance, the healthy cities, and also health literacy. In Taiwan, that we are almost finished our National Health Literacy Action Plan 2020. So they will be launched in January next year. We have our National Health Literacy Action Plan, including the health promotion, disease prevention, and medical care. And also they are including about the environmental literacy. This is some of the examples that we encourage people to participate in their caring, about the shared decision making, about the patient question prompt list, encourage the patient to ask more questions, engage in their caring process. And how about the prepare proactive practice team? Not only the responsibility from the patient themselves, but we also the provider is prepare of it. In Taiwan, we have the largest global level of health promoting hospital. We allow almost 150 hospitals participate in the global level about health promoting hospitals. And we also developed the guidebook, Health Literacy Organization Practice Guidebook. We encourage the health provider that they have provide health literacy information for the people, for the patient and their families. And how about the system, health system? And as you notice from the SDG, there is a goal saying that enhance the use of technologies, in particular ICT control for the NCD. So if for the NCD, we also incorporate with the technologist. Most people see the patient, see the physician, they ask Dr. Google before they visit. So Dr. Google, sometimes you have the information is true, but some is fake information. From WHO in this year, they launched about the recommendation on digital intervention for healthcare system strengthening. So from the development from Taiwan, we noticed Taiwan was very famous for ICT. It's from PC to internet to mobile social cloud, IoT, and smart machine. That is quite developed in Taiwan. For example, we have a smart healthy city project. People can get for he or her information from their own app and can take care of themselves. Also from the National Health Insurance, so-called the MediCloud system, they provide the information down to their own information. And this is so-called My Health Bank. People can get access to their own information and use the information that they take care of, engage in their caring process. And now for health promotion administration, we have developed our health cloud and integrate with the medical cloud and to be the personal health record in the future. And also for home care programs, as Professor Hancock, he mentioned about telemedicine. Actually, we have some telemedicine here, and the physical data are doing the home monitoring. And it's really important that the information was sharing with their families. Also for the My Health Bank, also the information is shared with their family, because as you notice, during the urbanization, isolation, disintegrate for the family is a very concerned issue. So the family caring each other using the information sharing is very important. And how about the aging? I think this is the most important issue that we have to facing. Taiwan population is reaching about almost 15% about the over 65 years old. And not only the population, but change of the aging is very fast. For the France, they take about 120 years. From Taiwan, Korea, Japan, it takes about 20 years. The changing is very fast. We only take 25 years to reach 7% to 14%. And there's a study recently, they're from a magazine. They ask between the year of 1999 and the year 2017, do you want to live until you are 100 years old? Very interesting result. In 1999, most people said that they want, they only, do not want to live in 17 years old, 77. But now there's more people do not want to live until 100 years old. So why even the improve of the technologies, urbanization, but people do not want to get older. Why? They care about the health, about the money, and also the friends. So social connection is one thing that we have to consider. Health is one major issue. So we see that yesterday that the intrinsic capacity is decreased because of the report from the WHO in 2015, the World Report on Aging and Health. We noticed as we are getting older, the intrinsic capacity decrease. The functional ability still also decrease. And if we divide it into three phases, one is the high and stable capacity, decline capacity, and then significant loss of the capacities. And if we can do something that we can improve the intrinsic capacity, and also something if we can improve the functional ability, that may improve our quality of life. So how can we do it? The health service the long-term care, and also the environment. This is the three major issues that we can target and guiding our intervention for the changing these issues. So in Taiwan, we start with the age-friendly hospitals, age-friendly primary care, and also age-friendly communities, because the elderly are living around these three places. So first, we are talking about the health service. We are incorporate the WHO age-friendly primary health care into the institution. So we allow all the health stations are accredited for the elderly-friendly primary health clinic from the health station. It almost reach 400 units. And as you notice that it is the strategies of the physical capacity. And A is the best one. Everybody want to do it because it's stay health and then die certainly. This is the best way that we want to end of our life. But I don't think you will be there here. Most of people going this track is that getting healthy most of the time and then getting sick. And then become, if you're doing good, you can go back to the healthy level, but sometimes slightly decline and then until the end of life. The poor is that when you get sick and then decline very fast. The C is the worst one, that we don't want to be slowly decline all your life. Today, that in this afternoon, Professor Samuel will give a presentation about the ACE that we introduced this year. They propose that during the acute care, we have to target on this situation, just like the red project strategies in the previous slide, that during the inpatient, in the emergency department and outpatient, if we target immediately, I think that we hope that they can gain back their health to the original state. So this is also the age-friendly hospital and health service increase very fast in Taiwan. And how about the environment? That we follow the age-friendly aging policies about the age. We start with 2002 about the and then we have the 2007 about the global aging cities guide. And that this is in target on 8 domains about the outdoor space, transportation, housing, social participation, all those things. So in the age-friendly city in Taiwan, we start with 2010, and now all the counties are involved in this movement that 20 cities are continue to promote age-friendly cities project. Not only the age city project, we have age-friendly groceries, pharmacies, restaurants, and also we target on national dementia strategy plan. This is our own logo. I like this logo because this is like the wing or the hands circling for the dementia people, their heart and the family. And also very important that they can have their independence. And this is National Dementia Strategic Action Plan. And now we start with the e-platform. As I just mentioned about the technologies, we use the television channel that is interaction. The people can, elderly can stay at home, interact with the people from the channel, and even they have friends through the television. This channel is very successful, and now they'll start with 16 pilot to 8,000, and now we're going to distribute all over Taiwan. The people can engage with this interactive television channel. And also we develop our so-called hub. It's the resources for elderly, for the community resources. And now about the long-term care and how about the dignity in life. This is the program, the long-term care 2.0, including palliative care. We are emphasized on, in Taiwan, we always, everybody know about the ABC program. But now we start with the D and E. What's the D is the domestic, dignities, digital, and dialogue, including the disabled, dementia. Including the E is about the environment, empowerment, and engagement, including the economic and eating and exercise. This is the report from Quality of Life Index 2015. Taiwan ranked number 6 among the 80 countries around the world. The quality of life index is quite high, and And they asked me to write a message. Why Taiwan leading the way? This is what I've written to the editor. It's a community engagement. And we also have the advanced directive. This is the insurance card. I just cover my age, but this is birthday is true. So you can put your wishes in the National Health Insurance card. And now we are start with the compassionate communities. We notice that as you know, during urbanization, people isolation without contact with each other, even you do not know who is your neighbor. But in this process, Professor Alan Cannon, we invited him to come 2 years ago, and then we have launched this program in nationwide. We hope that the age-friendly cities or communities, dementia-friendly communities, and compassionate communities working together hand in hand, that we can make some of the interaction between not only the hardware of the communities, but also some of the warming, or I think the feeling in the communities. So this is about the social economic change, population health is the public health action for us. And in conclusion, that the planet health, we have to think about in the new generations, about the patient-centered care, the digital health. And we don't have much time. The ice cap is start to dissolve, and we are it's no time for us to left. We have to start now. So I hope that this is the last slide from Health Promotion Administration is the promotion, prevention, protection, participation, and partnership. But now I add two more is the patient engagement and empowerment. That is the patient-centered care. Thank you.
In order to save time for panel discussion, I would like to introduce our next speaker, Professor Padmini Murthy. Professor Murthy is a physician, a trained obstetrician and gynecologist, and she studied public health and management. She received the Master of Science and Master of Public Health from New York University, and she is now professor of New York Medical College of the United States. And she has been representative of Medical Women International Association, NGO representative in the United Nations. And she is now the Secretary General of MWIA. And we would like to have her talk about a global overview of the progress and challenges in achieving SDG 3 and SDG 5 among women and children in urban area. Let's welcome Professor Murthy.
Thank you. First of all, thank you for having me. It's always a pleasure to come here. And I'm going to keep to time, and I think, thank you, this works. Okay, thank you. So I just wanted to basically, thank you. I think I'll use this, that's a lot better. Thank you. This is what I wanted to talk about. It's just a very brief snapshot of what are the issues we're facing with SDG 3 and SDG 5. My distinguished colleague talked about the whole picture, but here I'm just going to talk a little bit about how SDG 3 and 5 and how it's impacting all of us. And it's really, as you said, it is a three-dimensional puzzle. All the SDGs are interconnected. And I'm not saying that because I'm a woman and a mother, but if a woman's health is not optimal, the family suffers. It's a domino effect. It's like everybody gets affected. And as we know, just very briefly about the universal health coverage, because I had the privilege of attending the high-level political forum last month at the United Nations, where everybody is signing on, most countries, excepting the United States of America, signing on to the universal health coverage, the declaration. So one of the things we really need to be talking about is gender-based. Because the reason I use the term gender, it's not so much gender inequality, gender equity, but the term a lot of us are using now is gender harmony. We need to work with each other in order to promote SDGs and UFC. They're all interconnected. And as we go, like these are just the targets, as we know, of SDG 3. And one of the issues here, you say, like reducing maternal mortality. Unfortunately, even today in 2019, we are going into 2020, we have the ICPD 25 coming up in Nairobi next month. We have the United Nations celebrating its 75th birthday next year. We have so many milestones. But one of the challenges, we still have 300,000 women dying in childbirth every year. So that is really not something we need to be brushing off lightly, because as a trained OB and now somebody in preventive medicine, there is no cure, ladies and gentlemen, excellencies, distinguished guests, for maternal mortality, but it is preventable. That's the one thing you cannot cure, but it is preventable. So we really need to understand what are the challenges we are facing, and also, as we know, is to end all preventable deaths under 5, that is target 2, and fight communicable diseases. And thank you so much. You made my presentation a little easier because you talked about fighting infectious diseases. And also yesterday's speakers too were talking about that. And one of the big issues we have here is reducing mortality from NCDs. As we all know, NCDs are a major challenge, and especially NCDs among pregnant women is a double burden. Now, when we talk about, Target 3.5 is to prevent and treat substance abuse. I just want to talk about one thing, ladies and gentlemen and distinguished guests. We are on the crux of a major opioid problem. We have a big opioid crisis in the world. A lot of countries are really suffering from it. So this is something we really need to address, because in order to have healthy cities, sustainable cities, and to talk about, the whole theme of this Congress, which is so well put together, the Global Health Forum, if we do not address substance abuse, if we do not address these things, we are really going to have a bigger problem. And the other thing I just wanted to talk briefly about is the universal access to sexual reproductive care. It is really sad in this day and age that this young girl in Kenya committed suicide because she was shamed by her teacher for getting a period. In this day and age, we should not be ashamed to talk about a period. This girl was publicly shamed. So I just wanted to bring this. It is so horrible what happened, and those of us who work in reproductive health, we are really appalled about it. She was shamed by her teacher, she went home, and she killed herself. So my question here to you, ladies and gentlemen, how can we let this go on? Where do we have access to, reproductive health or basic healthcare services of making sure that a girl like this and other girls are not put to shame for a normal physiological phenomenon? So when, as a global community, we need to take a step and see, like, where is the human rights aspect here? Where are we going wrong? What do we need to do? And also, one of the other things I just wanted to talk about is affordable vaccines and medicines. When we're talking about Target 3B, one of the challenges faced is, again, gender comes into giving vaccines. I have worked with some of my colleagues in India, and they say that in some parts of rural India still, it's so hard to get girls vaccinated on the same par as boys. That is because of gender. And also there are myths, like if you give a child a vaccine, like, India has been polio-free for a couple of years, but there's still some other parts of the world which do have polio. It's also the socio-cultural factors, like you give a girl a polio vaccine, maybe she gets infertile. But the challenge here is it also says that because a girl is dispensable, that is a big problem. And Amartya Sen, one of the most brilliant minds of our century, in his groundbreaking article, 100 million women are missing, he discussed this very well, that how some girls even die before they're born because of infanticide and feticide. So when we're talking about what is the progress made, I think we have advanced in certain ways, but we've really gone back in many ways. And then we can see, this is a brief snapshot. As you can see, some of the gains made, with the births attended by skilled health personnel, but you can just still see the gap here and also the immunization coverage. So the reason I have these two next to each other, because it really gives us a snapshot of the progress made from 2015, as our distinguished director just said that, from the MDGs, from the M we changed to the S, the SDGs. So from 2015 to now, you can see the progress made, and there are still some gaps. So this really sets us wondering, as a global community, how do we address this issue? And then, while coming back from the progress, I'm an optimist, as most of us are in this room. You don't say a glass is half empty, you say it's half full. So the incidence of HIV among adults 15 to 49 in sub-Saharan Africa declined by 37%. This is something to be happy about, but it's only 37%, ladies and gentlemen. It's not higher. So we need to see, what do we do to make sure it's higher when we look at this in the next 3 years, if not earlier. And then the tuberculosis incidence declined by 21%. But you see, this is the challenge. 10 million people developed tuberculosis in 2017. So we need to ask ourselves, is it because of the environment? Is it because of a lack of screening? So it's a myriad of factors. And as I said before, in order to attain the SDGs or even to meet the targets, it's really a three-dimensional puzzle, and it's a work across disciplines. And now, this again, under 5 deaths, dropped from 9.8 in 2000 to 5.4 million in 2017. But we still have 5.4 million deaths. So again, yes, it's like saying, yes, we made something, but we didn't, it's not even, correct me, usually they say physicians are bad at math, but 9.8 minus 5.4, I don't think that's even a reduction in 50%. So is it acceptable for us? This is the question we need to ask ourselves. And vaccinations resulted in 80% drop in measles deaths. So that is something good. But again, if we look at it, how many girls and how many boys? So again, it's gender. It's not that I have anything against a man. Some of my good friends are men. I've been married to a man for more than 31 years. Thank you. But I'm just trying to say we need to address this. That's why I use the term gender harmony. It's not equality. We are working together to improve ourselves. Okay, and these are some of the unacceptable numbers. Still, according to UN Women, every day 830 women die from preventable causes. So we are talking about infectious diseases, we are talking about chronic diseases, we are talking about abuse. Unfortunately, violence against women and girls is a global pandemic. And you can see what this is resulting in. So this is really unacceptable. And let me move here, because my mic. So as you can see here, this is really the number of deaths while pregnant or within 42 days of termination of pregnancy. So this is a whole lot of issues here which come in. And due to the interest of time, I'm just going to, these are kind of self-explanatory. Now, this is another challenge we have. Yesterday, some of our distinguished colleagues were talking about Greta Thunberg when she said, "How dare you?" I had the privilege of listening to that young kid. She's like a little jalapeno pepper. She's on fire. She really sets the room on fire. But you see, again, we are not realizing climate change, pollution, so many things, resistance to insecticides. We have 13.5 million more malaria cases. And we know, according to research, that every time there's a 1 to 2 degree rise in temperature, you have increased number of malaria cases. So, and where is this? The highest burden, as you can see, ladies and gentlemen, is in the African countries. So in 1 year, from 2016 to 2017, malaria, 3.5 million cases of malaria. And you can see that in the map. Now, what are some of the other challenges? One of the other challenges is we have insufficient number of healthcare professionals, as you can see. And then, so all these affects the lifespan, affects the quality of life. So this is something we all need to be thinking about. And these are, again, limited progress. This is now, I'm shifting, connecting 3 to 5. I know my math. I skipped 4 because I see the connection between 3 and 5 for the sake of this presentation. Unfortunately, as you can see in Southern Asia, a girl's risk of marrying in childhood has decreased, but still 30% of women aged 20 to 24 for married before age 18. And a lot of these might be forced marriages. So what I'm trying to say, how it affects SDG 3, the health of women, health of cities, it's the whole thing. And then you can see women represent 39% of the workforce, but only 27% are in managerial positions. Why are we thinking about that? Because it also looks at the policies which are friendly towards women, gender-friendly policies. Are you taking into consideration a woman who just had a birth and she needs some time to feed her baby? What are the facilities? Is there a creche in-house for them? So these are some of the things we need to start thinking about. And then some of the challenges, as I just said, gender-based violence is a major issue. And even in this day and age, 18% of partnered women and girls aged 15 to 49 have experienced physical and sexual partner violence. And 200 million women have been subjected to female genital mutilation. And according to, this is still going on. So how can we meet the targets of SDG 3 and 5 when we still have this? And according to a report released by DAW, which is now a part of UN Women a couple of years ago, the youngest child or girl on record to have FGM was a 3-week-old infant from Yemen. So what I'm trying to say is these kind of practices really impact the health not only of women, but also children. So just wanted to tell you, these are, when we are looking at any slides, they are just not numbers. They're actual people like all of us sitting here. So sometimes I think, you know, I mean, okay, I'm a data person as much as I like it, but sometimes I think maybe we get too caught up with the statistics without thinking of really the people behind the numbers. Just that, I guess that's just my pet peeve. I wanted to share it with you. So this is really important, as you can see. How many people, and this, as I said, is the distribution per region. So you can see where the challenges are. And again, as you can see, in the least developed countries, landlocked countries, you can see the proportion of women and girls subject to violence. Okay. So, yeah. Women in power, as I said, 24% of national parliamentarians are women, which is really good. And as we all know, Rwanda has the highest number of women parliamentarians, which I think is really great. So you can see, again, breaking down the proportion of women here in managerial positions in various countries. Now, it's interesting if we compare this, and I would say that to the young students in the room, just see what is the health status in these areas where there are more women in top positions. That's some food for thought, I think, which we should all be thinking about. And then gender budgeting, there is a new term which is being used called gender budgeting, because specifically in the budget of the countries, how much of it is given to women and children. So this is a term now used in gender budgeting, and a lot of us who are into women's studies are looking at it. What proportion of the dollar or what slice of the pizza is meant specifically for women and not taken away from them? So that's another thing which also we need to be thinking about. And again, when we are coming to sustainable cities, as I kind of wrap up my presentation, more than 50% of the urban women and girls in developing countries live without access to water, improved sanitary facilities, durable housing, and sufficient living area. And if you don't have durable housing, you are more prone to violence. Because unfortunately, even in New York, I'm from New York, and I always tell my students, I took them for a field trip to see a domestic violence shelter. Let me tell you, in Westchester, where I work, where my medical school is, I wouldn't mind checking into that domestic violence facility because it's like the Hyatt we are staying in. But if you go down, if you go to the Bronx or Brooklyn or some other place, it's infested with roaches. And these women are abused in the shelters. They get away from abuse. So it's jumping from the fire, from the frying pan into the fire. So again, economics plays such an important role in what kind of services we provide our women and children. And again, 2 billion people do not have access to waste collection services. This is a major, major problem. We are talking about sustainable cities, so we need to be thinking about this too. And 1 out of 4 urban citizens live in slum-like conditions. And then you showed us the picture of the pollution. So there, just to strengthen what you said, 9 out of 10 urban residents breathe polluted air. It's terrible. We're not even aware of it. And also in and I think, some cities like Beijing, Delhi, they have a competition. They're in the Billionaires Club, but they're also in the most polluted cities club in the world. So what is being done about it? And I was talking to some of the colleagues who came from India, and they said that during the winter, they burn the husk from the paddy, so that's an increased pollution in the air. And who is most affected? It's the women, because a lot of times women are the ones who are working in the fields. Okay, so limited progress. Now, 150 countries have developed national urban plans, but half of them are only in the implementation phase. And that is not a picture out of, it's not a make-believe, it's not a doctored picture, but this is how most people live in urban slums. So one of the other things I just wanted to briefly talk about, you can see the percentage of municipal waste collected here and what the challenges are, and also the population living in slums or informal settlements. Today we are living with so much of political unrest. We have so many migrants escaping violence, coming to other countries, and where they stay is really not acceptable. And they face so many problems, especially women and girls. So again, this is something we need to be concerned about. And as you can see, the ambient exposure to the PMI in urban areas, you can see where it is, and you can see the countries where it's really high, 35 to 50, and then 25 to 15 to 25. You can see the most polluted cities in this map. Now, almost coming to the end of my presentations, who are the stakeholders? All of us, governments, the UN agencies, civil society, academia, think tanks, foundations. So all these people are the global stakeholders. So recently there was a call to action by, for healthy lives and well-being for all, and uniting to accelerate the progress. And as you can see, this is a great document. It's available online. It's a joint initiative of Gavi and the UNAIDS and so many other stakeholders. So one of the main things which the UN is working on, and it's nice they took the input of some NGOs also, it's to align, to build alliances, to accelerate, to account. That's important. And advocacy. And I always say advocacy with practicality and a commitment. And the last thing I added was to make sure there's gender harmony and gender equity. So these are some of the strategies which we really need to use to move ahead. And these are some of the accelerators. One of the things I would like to focus on in community and civil society engagement, which I think the Taiwan Global Forum, you are at the forefront because of all the engagement you promote at this forum. And also innovative programming in fragile and vulnerable states for disease outbreak responses, because as I always say, we need a visa or a passport to travel, but not a disease. It's not going to knock over your door and say, can I come and infect you? So that's something we all need to be working as global community. And so these are some of the criteria. And also catalytic, we have to be catalytic and disruptive, and the country impact. It just cannot be one country, but also global. So briefly, I just wanted to talk about an example. They have the Swasth Bharat initiative in India, which is kind of, building onto the universal health care. And the last one, I really like this quote from Gro Harlem Brundtland, the former executive director of the Director General of the World Health Organization, is when public and private sectors combine intellectual and other resources, more can be achieved. And I think that's something which is really being done here. And it's thank you in all the different languages, because there's so many people here. And thank you so much for your time. And I think I kept your time. Thank you.
To save time, I would introduce to you our next speaker, Professor Masami Jimba. Professor Jimba, he worked 2 years as a physician. Then he subsequently studied in public health in Tokyo and Boston. And he received his master's degree from National Institute of Public Health in Japan in 1989, and PhD from Hamamatsu University School of Medicine in Japan in 1995. Professor Jimba's research interests cover health promotion, global health, human security, and other broad public health issues in the world. He has published over 260 articles and more than 10 book chapters. He is currently interested in positive deviance approach. As he will show us how to do it. And let's welcome Professor Jimba.
Thank you very much for your kind introduction. Today, my topic is helping the poor, not the places. And the keyword is no one leave behind. And then solutions. When I was a medical student about 40 years ago, my mentor used to tell me, we must be solution-oriented. We have to use available resources to solve the problem of the world. And this is something I want to say today. And 3 years ago, when I came here, I made one presentation about leaving no one behind. It was the year when SDG started, and one of my key messages is this. A nation should not be judged by how it treats its highest citizens, but its lowest ones. This is a message from Mandela. And I think this is important. This is related with no one leave behind. And the British organization Overseas Development Institute made a very interesting document. And they said the first 1,000 days is a key to make a success in SDGs. And do you know how many days have already passed? Today is 1,390th day after, supposing that the starting day is January 1st of 2016. So 1,000 days have already passed. the question is, what's the progress? And the same institute created Leaving No One Behind Index. They made it in 1970 using several indicators. They also developed this outcome index. And if we look at this, you can find high and middle income countries performed well, but not so much in low income countries. Many countries are not on track. But this is a country level comparison. For urban health, we have to go into details. And before moving to the urban health, I want to show you how is it written in the UN document about this keyword, no one leave behind. So this is shown in the document, and these people written in red are the people who are at risk of being left behind. Children, youth, people living with HIV, or indigenous peoples. There are many others, homeless, migrants. And this is a situation of urban. And if you look at this, they are suffering a lot, mostly because of environmental reasons. So in this sense, I think highlighting environment for this year's conference was a right choice. Of course, health system is important, but they're suffering from poor environment. And particularly homeless people. Looks like it's increasing in many parts of the world. In UK, homeless people are dying more. And in the United States, Trump has no clues about hopelessness. Looks like he has solutions for some other issues. And in case of Japan, homeless people are decreasing, but it is not easy to count the number of homeless people. Do you know how to count? There are several ways, but one way of counting is to count the number of sleeping homeless people at night. But how reliable it is. So it is very difficult to count, but somehow we have data. And against urban health issues, or urban issues in general, Dr. Grazer wrote one chapter about it. They are suffering from environment, poor places, but improving places costs a lot. We should help the poor people, not the places. This might be a good solution for it. Then how we can do it. Then coming to my favorite topic, positive deviance approach. And I have been working in the field of global health for about 25 years. I started my career in Palestine. I made the first WHO office in the Gaza Strip, closely worked with Yasser Arafat for 2 years, and then I moved to Nepal for 5 years. My target area is a very, very rural area where there's no electricity, no motor road, no telephone, nothing, just bright moon or stars. Beautiful place, but they are left behind. And in the field of global health, the current situation is very much data-oriented. And many researchers are interested in showing how to interpret the world. It is good, but the number is not everything. One of my PhD students work in Zambia for getting her PhD. And after collecting data, she said, my research data are beyond the numbers. Behind the numbers, I can hear the voice of mothers. I can see the lives of children. She could say it because she collects data by herself. And that's what I'm encouraging to my students. And what she told me was really touching. So, although numbers are important, we have to always think about what's behind the numbers. And this is very good criticism from a medical anthropologist, and I'm following it. And one of the way to go beyond the number is positive deviance approach. Some people can find better solutions to a problem than their peers, even if they are in the same poor conditions. And these people are called positive deviants, and their behaviors are called positive deviance. And this approach is assets-based, problem-solving, and community-driven. And the basic textbook is this, The Power of Positive Deviance. And it's taught in Said Business School in Oxford. And in the past, it used to be used as a text in the Harvard Business School. And my school is also teaching this positive deviance approach. And Tufts University in Boston is also very famous for it. And the first case came from Vietnam. In the 1980s, they suffered from malnutrition or undernutrition. 2/3 of under 5 children suffered from undernutrition. And the typical approach was giving food or protecting children from diarrhea. But they means UN organizations or INGOs, they came, they fed, they left, and nothing changed. Poor sustainability. So to overcome this issue, Save the Children United States came to Vietnam. And when they conducted a baseline survey, they found 64% were undernourished among under 3 children. But they forgot about it. They didn't care this undernourished 64%. They wondered why 36% were well-nourished. They live in the same poor family, but why they are well-nourished? This is a very new way of looking at the situation. Then they found 3 uncommon behaviors. Mothers feed children small shrimps and crabs, which are freely available from the rice field. And they feed it 4 or 5 times. Usually in Vietnam, they eat twice. When parents eat, children eat. But when parents went to the field, siblings and grandparents fed more. Then when they observed the eating behavior, they found mothers washed baby's hand whenever children touched something dirty. So hand washing was not a ceremony. It was a meaningful practice in this family. And just with these 3 reasons, these 36% of children were well nourished. No support from outside. Answer was there. And this is successful cases of positive deviance. And after that, they tried to improve the situation of 64%. They invited mothers to a home, and they trained mothers for 2 weeks, getting shrimps and crabs, fed more, and wash hands. It became a kind of custom. In 2 weeks, and mother's body weight of babies, more than 80% improved within 2 weeks. And then it was scaled across all over Vietnam. The important thing is it was not scaling up. Later, I will explain the difference between scaling up and scaling across, but they repeated the process, not scaled up the same 3 behaviors as it was. They found out positive deviance in each village and identified 3 or 4 behaviors and used it in the village. And this, they call it a living university. Then how about PD approach in urban area? The first case was done in rural area, and many PD approach has been done in rural areas. In urban area, it is not very common, but when we conducted a quick survey, we found several cases from India, Japan, Singapore, and others. Most nutrition related. And today I want to show you 2 cases, one from Japan and another from India. In Japan, tuberculosis used to be a major killer after the Second World War. Still, it is a problem compared with other high-income countries. And the prevalence of TB among homeless is worse than that of low and middle-income countries. So TB is a big issue in Japan. And one Japanese agency conducted a survey, a research about TB problem in homeless people in 4 big cities in Japan. And the finding was very important. The approach is listen to the voice. The question was why you do not come to the hospital. It's all free in Japan. But these homeless people did not want to come to the hospital because if they are hospitalized, they may lose their favorite place in the public park. Or if they are hospitalized, what to do with my dogs? Who give food for them? So they are worrying about these things. And they are afraid of being scolded by doctors and nurses. So although it is all free, they didn't want to go to hospitals for treatment. And then research team. Did something unusual. By the law, in Japanese law, these people must be treated in the hospitals. But they worked a lot for the policy. They negotiated with the bureaucrats, and they got approval that treatment can be done in the public park. So this is called the blue, under the blue sky dots. So homeless people do not need to go to hospital. They can get treatment in their park. And their worries are all solved by this. So what makes their treatment difficult is, listening to these reasons is very important. And by this, they could solve the problem. Then some of them, as positive deviants, started to work as volunteers to help other homeless people. It was unusual. It was something we did not expect. And then their community became much healthier. No support for improving the places, but by supporting the poor, they improve the situation of the community. Human relations can get much, much better. And positive deviance originally is an approach to change difficult behaviors. It is used in over 40 countries for many topics. But sometimes it changes the society naturally, not by force. And this happened in this community. The next case is India. Undernutrition is a big issue in urban settings rather than in rural settings. So an Indian team conducted a positive deviance study how to improve undernutrition in India. And they found these uncommon behaviors. So when the family with good nutrition, children were fed more frequently. And most of the children ate with family members, not alone. And also, mothers fed less diluted milk. And in a family with poor nutrition, they said, a mother said, by adding more water to the milk, it is digested easily. If less water is added to the milk, then it becomes difficult for the child to digest it. So they have this kind of understanding, and that's not correct. And when they observed environment, they found it's very clean, nice. But for the family where nutrition level is not good, the hygiene level was very poor. There are many other reasons to explain why the mothers of positive deviance was good. So in the paper, nothing was written about scaling across, but I think positive deviant mothers can work to encourage this eating behavior, or can improve environment. So in the beginning, I said there is a difference between scaling up and the scaling across. Scaling up is exporting programs from one place to another, the same way as it is. And scaling across use specific modifiable tactics. And fidelity is a key word. To use the same method as it is. And they prefer RC designs. They prefer uniformity. But scaling across highlight the importance of adaptability or flexibility. And diversity is a good value in scaling across. So we are living in a world where it is very diverse. So rather than scaling up, I think we should scaling across. So the conclusion, no one leave behind, is important. What I feel these days is the people who are at risk of no one leave behind may be increasing. If the number, and no one leave behind is a core or overarching principle of SDGs. But if these people are increasing, which means SDG is not successful. Something much bigger power, upstream events are going on in the SDG era. And we have to know who is, what it is, and we have to tackle against this. And particularly in urban health. The ODI document said high-income countries are doing well, middle-income countries are doing well, but this is country-level analysis. Within, even in high-income countries, we should not forget. And then help the poor, not the places. The poor people even can do something. And rather than technical solutions, adaptive solutions, like I show you in homeless in Japan. This is critical. And PD approach is good, and we should think about scaling across rather than scaling up. Yeah, these students helped me to make this. Thank you very much.
And I would like to call all the invited speakers on the stage. We will have 10 minutes panel discussion. Questions or comments are welcome now. Please, proceed to the microphone.
Hello, hi. I'm Ling Hiu Chen. I'm the president of Taiwan Occupational Therapy Association. I have a question about for Dr. Junba, and that I appreciate your presentations on bringing attention to understanding the individual behaviors, you know, how they and the attention to the minority or disadvantaged group in urban areas. And I was wondering, from yesterday's presentation to today, the emphasis mostly were on what government can do to do health promotion. And I was wondering, what do you see about the role of the government in terms of promoting a positive deviance approach? Because what you are saying in your presentation is mostly to change individual behaviors, right? So when we talk about a disadvantaged group where the health behaviors, and you want to change the individuals. And I was wondering, you know, what do we do as a policy or as an environmental approach then that we can do to adopt this? Thank you.
Thank you very much for your question. As I already mentioned, I think the government should work on the upstream issues. And health promotion research has proven that only empowerment does not make sense. Some kind of political support is necessary, or else only bottom-up approach does not make sense. However, we don't know how long it takes for the government to improve such kind of supporting mechanism. We say upstream, attacking upstream is important, attacking big business is important. However, we don't know how long it takes. So, and we just cannot wait for it. So two approaches should go hand in hand. And academics, we should tell the voice of these people to the world beyond the country, and getting more support from all over the world. Only one government may not be aware of the importance of supporting these people.
I just want to add that in response to these questions about the positive deviance, or actually we mentioned about the positive deviance, or also about the asset-based. Actually, from the Health Promotion Administration, we started last year about we're using not only from the top down, but also using the design thinking process, notice for the deviance, and also from the perspective from the individual, rather than just based on the quantitative data. We also need to use the qualitative data to change the society.
I'm wondering, should we pay the positive deviance? Because if they are professional all-day service, and what do you think?
If you pay, people may be dependent on money, so better not to pay. And this is my impression to scale across. But if this is very professional support, we may consider to pay, but using less money to make it sustainable is the way positive deviance approach should go.
So thank you. My comment is also to Dr. Jimba. I'm going to take issue with one word in your title, and that is not. I think it would be a lot better if you talked about help the poor and the places, because what you seem to imply is we don't have to worry about the places, we just help the people. And I think that's a mistake. For example, you talked in your presentation about feeding food diluted with water, but if the water is dirty, if you don't have clean water, if you don't have sanitation, if you don't improve the place, then it doesn't matter how much you educate, and it's not going to solve the problem simply to focus on the people. You have to improve the place as well. So I question why you have the word not in your title. It would be a lot better, in my view, if it was help the poor and the place. And your comments are welcome.
Thank you very much for your comment. Maybe this is dependent on context. And in many cases, what you mentioned is true. And I agree with you. But the changing the place, it costs money. And changing behavior or the people may not. So first starting point, maybe improve the poor, and then place. So, but helping the poor first, and then helping the place next. Or, if possible, do both at the same time.
So thank you very much again for the great presentations. I loved how we got a worldview of what's happening in Taiwan, but then some interesting aspects of gender harmonization, and then also this idea of positive deviance versus also just what we were talking about do you think about place or do you think about behavior? But I guess the question is, if we're thinking about public health, I see a lot of competing agendas. Almost, what do you tackle first? Do you tackle climate? Do you talk gender, behavior? How do we actually advance this with so many different priorities at the same time? Like, where would you start? And I might start with Dr. Wang and say, where do you make those choices? Because if you're focusing on children, are you doing that at the expense? Because you can't do everything at the same time. So how do you suggest we start prioritizing to get all of these important issues, done?
I think that data is very important, collect data, because we have some of the national surveillance. But the data are also so-called quantitative data, just telling the problem, not telling the solution. So we need to focus on certain priority. I think that is, and also we start with the ecological approach, from individuals to communities to the national wide. I think that is, for example, we're using the health promoting school, for example. We start with the school base and the county base and also the national base. You have the target in the same time. It's a multi-level approach rather than just one target. Because if you want to change it, you have to think as a whole system rather than just one individual.
To the time limit, the last question will be addressed to Professor Murthy. what do you think is the most important and effective one to promote gender harmony?
Thank you. I knew you would ask me that question. So I think, gender harmony is still, as we know, in its infancy, but one of the things which we have found, and what I have found, if I may say so in my personal experience, is to have the men work with us. Because remember, in the spelling of a woman, there is a man included. I'm not being a feminist here, but we cannot do it alone. We need to work with our male colleagues. And as you said, the ecological model, and I would like to further add, if I may, like think globally, but act locally. So unless you act locally, and then you have the domino or the effect. So we need men. We can't do without you to get this moving. So it needs to be an inclusive effort. So that's the first step, I would say, in gender harmony. Thank you.
Thank you much. And I have to close this session and thank every distinguished guest and everybody joined this session. Thank you.
Ladies and gentlemen, did you like the exercise yesterday? Yes? Let's do it again. Please, come. You said yes. Well, we're going to do it anyways. And then we finish the exercise, we go for the coffee break, okay? Ladies and gentlemen, let's do this exercise together. It's very good for your health, really, okay? Music.
Hello, everyone. Now let's put away our work for a while and join in the health exercise for office work. To the right. To the left. Depress your shoulders. Relax your body and ease the tension of your body. Protraction and retraction. Forwards, backwards. Do you feel the relaxation of your shoulder and neck muscles? Shoulder exercise, backwards. Lift your shoulders. Raise and step tap. Keep on tapping your feet. Right, left, right, left. Extend your arms up and squatting up exercise. Slightly bend your knees. Swing your arms like you are jogging. Biceps curl and squatting up exercise. Stick your upper arms close to your body. Flex your elbows like you are lifting dumbbells. Now it's getting harder. Lateral punching upward and squatting exercise. Punch the sky. It's getting harder now. Pushing forward and squatting up exercise. Push as far as you can. Chest stretching exercise. Sit as low as you can. Change to right. Quadriceps stretching exercise. Bend your leg and support it with your hands. Do it as far as you can. Get ready to change to the other side. Remember to stick your knees together. This is the extension of our front thigh muscles. Posterior deltoid stretching exercise. Get ready to stretch your shoulders to the right. Remember to straighten your body. Do not turn with your shoulders and don't compress your elbows. Tricep stretching exercise. Change sides. Chest and shoulders stretching exercise. Stretch your arms behind your back and stretch your chests. Upper back stretching exercise. Put your hands in the front like hugging a ball. Thank you and have a great day.
It's time for coffee break. We have coffee, tea, and desserts on both sides. And just FYI, we have web livecast on YouTube of the conference and the exercise. You're all in it. Thank you. Enjoy the coffee break. And we come back at 10:40, please. For the VIP delegates, if you need to use the room upstairs, it's room 201. Refreshments are served there as well. Thank you so much. We come back at 10:40, just a few minutes away. The VIP room upstairs is 202. The VIP room upstairs is 202 for your refreshments. Ladies and gentlemen, we have to get started with our next session. So if you're inside the room already, please be seated. Thank you so much. And if you can hear me from outside, please grab some coffee and come in the room. We're going to get started with our next session. Please, thank you so much. Okay, ladies and gentlemen, we're running a bit late, so let's get started. Introducing our next moderator, please come onto the stage. This is Professor Cordia Chu. She's director from the Center of Environment and Population Health from Griffith University. I believe that's in Sydney, right?
No, Brisbane.
Oh, it's in Brisbane. Okay.
A nicer city.
Next to Sydney. Okay.
A
Ladies and gentlemen,
city.
Professor Chu from Brisbane.
Okay, we better start it because I think they want to keep to the time. If much time we can save, the more we can have discussion. Or we have to cut the discussion altogether. So this will be the last session of today's plenary, Sec 2. From a lot talk about the Sustainable Development Goals, how to achieve it, are we there yet? And some of the particular approach to hopefully to get there. And now we'll have three speakers. Two of them will deal with data. And they all show us how data can help us to understand better the problem and even enhance our ability to address them. And then there was one about placemaker. So I can't wait to hear from them. So as people are moving in, maybe I should invite the first speaker. This is going to be challenging, but hopefully I can spell it correctly. We have a very young, brilliant scholar who are epidemiologists, but also have an economic background as well as policy management. what a perfect combination to inform us how to use data to advance our global health cause. So we have Dr. Joreintje Mackenbach from Netherlands, please. Yes, she will tell us something very important, not only about how to collect, innovative way of collecting data, how to use the data, how to also make the maximum use of data in order to develop, to enhance policy or the solutions. So.
So thank you very much for being here today. And thank you for the organizers for inviting me. I feel very honored to be here at this very interesting session. And of course, it's always a great pleasure to talk about my work. So I'm happy to be here today. Before I start, I just want to say that I do not have any conflicts of interest to report. Let me first introduce you to my urban environment. This is the beautiful city of Rotterdam, the Netherlands. It's my hometown, and I love this city. It is great for cycling. We have a great cycling infrastructure. We also have a lot of opportunities for public transportation, a great network, so there's really no need to use any car. As you see, it's not very green. It's a lot of gray buildings. But there's also a great land use mix. So there is a great mix of housing, offices, retail, all combined in one city. And then a little bit about my work. In my work, I focus on the environmental or upstream determinants of lifestyle behaviors and chronic disease risk. So for example, I investigate to what extent green spaces in a city are associated with walking and cycling or other physical activities, and to what extent this in turn is associated with obesity or type 2 diabetes. But I also focus on the food environment and how that influences what we eat, and that in turn influences our risk of cardiovascular diseases. Today we will focus specifically on urban environments and how that influences our health. And I will be showcasing the European Spotlight project to show you some examples of such associations. And then we'll go into what data and data sources we can use to study these relations. So let's first speculate a little bit about what we think is a healthy urban area. What do we expect of our urban environments? Do we want them to be safe, socially inclusive, generally a happy place? Do we want our urban environments to provide access to healthcare, job opportunities, healthy food? I think it's important to create a vision for our cities and urban environments. What do we expect of them? And then we need to investigate the status quo. How are we doing at the moment? And given the likely mismatch between what we want from our cities and what is actually happening at the moment, it is important to identify those levers for change. But today we'll be mainly focusing on how to examine the status quo, how to examine what our cities and urban environments look like at the moment. So I will be using the European Spotlight study as an example here. This was a cross-European project where, with a large group of consortium members, among which Professor McKee, we investigated the individual and environmental determinants of obesity in adults. And we used a range of methods. Essentially, we first mapped the obesogenicity of neighborhoods. So to what extent do neighborhood factors promote or prevent obesity? And we also asked individuals what they thought about their environment, what were their perceptions, but also we asked them about their body mass index and lifestyle behaviors. And I will go into the details of the methods we used for this study a little bit later on in the second half of this presentation. But with the methods we used, we really got fantastic insights into how urban environments influence lifestyle behaviors and health. And we got so many insights that from this 4-year project, we published over 30 publications with this data. And I'll show you some examples now. But before we started, we thought about what are the different environmental factors that may be of interest. And there are many. So we decided to use this NGO framework to distinguish between different types of environments and different levels of environments. So we distinguish between the physical, the economic, policy and socio-cultural environment. And then we can also distinguish between the micro-level environment and the macro-level environment. And in the Spotlight study, I would say we focused on the micro-level environment. So we focused on neighborhoods, although within the project we had some discussion that we would have preferred a level in between, so perhaps a meso-level, so that it's easier to distinguish between the real micro-level environments, such as workplace environments or indoor shopping environments, and at the meso level, the neighborhood. So what do we find in this project? This is an example of a study published in Obesity Reviews, where we linked social capital in the neighborhood to risk of obesity. And we found that in neighborhoods with larger social networks and stronger social cohesion, individuals had a lower odds of obesity. And in this study, we investigated what built environmental factors were associated with cycling for transportation. And we found that neighborhoods with lower speed limits for cars, so neighborhoods with a maximum speed limit of 30 kilometers an hour, and neighborhoods with more bicycle lanes were associated with more cycling. There were other factors that also played a role, but these two were the most important ones. And also importantly, these were quite universal in the sense that this was true across different European countries, but also across different subgroups of the population. So both for younger and older adults, for males and females, for those with a lower and higher education. So these seem to be a real good starting point for improving cyclability of urban environments. We were also interested in the food environment, and in this study we investigated to what extent access to grocery stores, where you can buy ingredients to prepare your own meal, and to what extent access to restaurants, where of course the meal is prepared for you and you don't have to do anything yourself, would be associated with the frequency of home cooking, an important dietary habit. And we found that while access to stores was not associated with home cooking, having better access to restaurants was associated with a lower frequency of home cooking. And this may suggest that, at least in this European region, we may not only want to promote access to healthy foods, but also maybe limit access to more unhealthy foods. And in this study, we investigated the importance of individual perceptions of the environment. So we linked objectively measured access to parks and recreational facilities to individual physical activity behaviors. But we also asked our respondents whether they thought these facilities were actually available in their neighborhood. So what are their perceptions? And we found that the access to parks and recreational facilities was only associated with physical activity if the individuals perceived them to be available. And then again, those who perceive these parks and recreational facilities to be available and also use them, obviously even at higher levels of physical activity. But we also asked people, so why do you use these facilities, or why don't you use them? And actually for both, the proximity was an important reason. So having these facilities close by was an important reason to use them. Having them much further away was a reason not to use them. But it's also important to remember that all these factors do not operate in isolation. They are part of the urban ecosystem. Food environments coexist with recreational facilities and transportation and housing. So in this study that was also published in Obesity Reviews, we looked at the cluster of these environmental factors. And for example, the green cluster on the top right, shows that in areas where there were a lot of food outlets, which may be regarded as a bit more unhealthy element of the environment, there were actually also a lot of recreational facilities. So neighborhoods often consist of both healthy and unhealthy elements. And this is, I think, really important to take into account. So let's continue to data and data sources. So let's remember why we need the data. So we have this vision of our urban environments, what we want them to look like, and we need to investigate the status quo. And given that there are so many data available, it's useful to classify them into a couple of categories. And we can use these categories both to describe what our status quo is, but also to describe our vision for these cities. And what is needed to investigate the relation between urban environments and health? If we have that vision, we need to define exactly and precisely what we want to measure. So we may have the idea that, for example, green space in urban environments is related to better physical and mental health. And that may be so, but what exactly do we mean with green space? Is that the surface of grassland? Is that the number of parks? We need to define that quite precisely. And then if we've defined what we're actually interested in, we need to find the tools that are best suited to measure this. And we want these tools to be valid and reliable. And often it's quite useful to have context-specific tools. For example, if you compare population density in Taiwan compared to the Netherlands, that is very different. If you compare the cycling infrastructure in Taiwan to the Netherlands, it's very different. So it's often useful to have a context-specific tool. On the other hand, there may be situations where you want to use a broadly applicable tool so that it will allow you to compare your status quo with other urban environments where they've used the same tool to measure the urban environment. And of course, all of this research requires resources in terms of money, manpower, etc. So let's have a look at a number of types of data and data sources that we may be interested in when investigating effects of urban environments on health. And this is by no means an exhaustive list. It's just a list of examples of what you may be interested in and what kind of tools you may use to investigate this. So obviously there is a lot of interest in air pollution at the moment. And two tools that may be used to investigate this is the use of either static air pollution devices that are stationed at one point in an urban environment, or handheld devices that individuals in the city carry around. And obviously both of them have advantages and disadvantages. So if you ask individuals, your citizens, to walk around with a handheld device to measure air pollution, you will get a measure of air pollution at much more places in your city. On the other hand, the static devices allow you to measure air pollution at the same point in your city, but at different time points. There is also increasing interest in UV exposure and protection from the sun. And you could use, for example, light radiometers to measure this, but you could also think of wearable cameras where your citizens wear the cameras to see in what areas they could be protected from the sun. In many instances, you may be interested in land use mix and may be able to use data from existing land registries. If you think about the Green Vegetation Index to have an indicator of green space in your urban environment, you may be able to use satellite images or remote sensing. As we did in the Spotlight project, if you're interested in neighborhood characteristics, you could use virtual or physical street audits. And similarly, you could also use such audits to measure the location and density of food outlets. But in some cases, you may have other data available, such as commercial databases that have data on food retailers available. But of course, we want to link this to health outcomes. And there is a wealth of health data from registries, pharmacies, census data, surveys, etc. And especially if you have data on the home location of the individuals within these registries, it's easy to link them to these environmental measures. But to get a better insight into the mechanisms of how urban environments influence our health, it is also important to get these individual measures of how do people perceive their environment, what are their lifestyles, what are the individual factors influencing their health. In some instances, you may also be interested in individual direct responses to the environment, and you could use ecological momentary assessments to investigate this, where individuals receive prompts or questions if they are located in a specific area in your urban environment. And lastly, if you're interested in making your urban environment healthy for a specific subgroup, you may want to know where these subgroups are going in their daily lives. For example, if you want to make urban environments more walkable for elderly people, you first want to know where do these elderly people go, what parks do they actually use, etc. And you may use, for example, GPS tracking or GPS measures on mobile phones to get an insight into this. So we can also classify these tools and data sources into a number of categories. So there are field-based observations. So the audits or checklists are still the golden standard in this field. But you can also use remote sensing or geographical information systems. Think of, for example, Google Earth or OpenStreetMap. There are many surveys and registries that may have data that are of interest to you. And try not to think only about health-related surveys, but surveys like household travel surveys or time use surveys, they may also provide really relevant insights into how the environment is linked to lifestyle behaviors and health. And then, of course, there's the individual devices that you may use, and a lot of these devices can actually all be combined into mobile phones. They have so many applications available. And of course, there's publicly available big data. And think of, for example, data from Twitter or Google Trends. So I will now tell you shortly a little bit about the methods we used in the European Spotlight project. So we wanted to map neighborhood environments across different European countries. And we decided to develop a virtual audit tool which consisted of a checklist of 42 items. And we conducted this audit across 60 different neighborhoods in different European countries. And in each of these neighborhoods, we walked through all the streets in the neighborhoods. I think in total there were over 5,000 streets. But we did this virtually. So we used Google Street View to walk through these streets. And for each street, we completed this checklist of 42 items. So we really got a wealth of data from all these audits. But of course, given that physical street audits are the golden standard, we wanted to know if performing a virtual audit would result in the same valid and reliable results. So we both did these virtual audits, and also in a selection of neighborhoods, we performed physical street audits. And these physical street audits were performed by a number of different observers, and some of the neighborhoods were done twice by the same observers. And then we found that actually the intra-observer reliability and inter-observer reliability was really high, so the tool did good. The criterion validity was also substantial to high. And actually the items where the tool scored lower were the items that required a subjective interpretation by the observer. So for example, how attractive the street was or how aesthetically nice the street was. And the big advantage of the virtual audit tool was that it was much more efficient than the physical audit, so it was twice as fast. Still, performing these audits was quite laborious and time-consuming. And when we designed this tool a couple of years ago, it was quite novel to use Google Street View. But now there are groups all over the world who have developed new tools and new ways of measuring. And I would just like to show this example from this group from Japan, who developed this walkability checklist of 14 items, but then decided not to rate these 14 items for streets by trained researchers, but they decided to get paid crowd workers to do this work. So those are just citizens who were a member of a paid crowdsourcing platform, and they asked these individuals to perform these checklists. And the researchers were interested to see whether asking citizens to do these audits was just as reliable as asking trained researchers. And the answer is yes. So this worked really well. It saved the researchers a lot of time mostly time, and they still got valid and reliable results. What needs to be noted is that this was a relatively simple checklist, 14 items, all yes, no answers. And the 2 items that also required more subjective interpretation about attractiveness of the streets scored a little bit lower, just like in our study. And in the meantime, new developments are going on. So there's increasing interest in using machine learning, for example, to perform these audits automatically. Of course, when that is going to be possible in a valid and reliable way, that is going to save us even more time. So I think one thing I want to emphasize is that we really need to be sure that we are measuring what we want to measure. If you use the wrong indicators, you will get a completely different idea about how your urban environment is doing in terms of promoting health. And I'll just like to go over these 4 examples where I think we should be critical of assessing whether we are really measuring what we want to measure. So Twitter allows you to analyze geotagged tweets. You know where this tweet was posted and at what time. But we should really wonder where geotagged tweets about, for example, anxiety actually give us an impression of the geographical spread of anxiety. Because who is tweeting about anxiety? And at what point in time do they do this? And where do they do this? Do they do this at the exact moment they are anxious? Or do they wait until they're at the airport and they have Wi-Fi again? Or do they wait until they feel that they can talk about it? And the same for example, the surface of green space. This may be a great measure for measuring access to green space for your citizens. But if the green space is all on a very hilly terrain with no access for humans, then what are we really measuring? Is that measuring access to green space? Similarly, I focus a lot nowadays on food environments, and we should really wonder whether a simple measure like the density of fast food outlets really represents unhealthy food environments. There is so much more to the unhealthy food environment. Supermarkets also sell unhealthy products, and there is a lot of marketing out there that you're ignoring if you're just focusing on the density of food outlets themselves. And then related to bicycle lanes, if you think, well, let's just implement bicycle lanes and have them everywhere, and then people will start cycling, that doesn't always work like that. Citizens also have to feel that cycle lanes are safe to go, pleasant to make a bike ride, etc. So you have to have an idea of these perceptions as well. So I'll just spend one slide on identifying levers for change. So once you've discovered what urban environmental factors are related to health outcomes, you may want to implement policies. But in some instances, it may be a bit scary to just change the urban environment. And in that case, it may be interesting to test some of these ideas that you have in virtual realities. So this is an example of a virtual supermarket study that we conducted last year, where we used a virtual environment for individuals to do their shopping in to test the effectiveness of unhealthy food taxes, healthy food subsidies, and nudging in the supermarkets. And the advantage of using this approach is that it also allows you to more precisely investigate the effects of your changes in your environment. So this is an image of an eye tracking study where you can actually see precisely where the participants of this study have looked at. So you can get a better idea of whether people actually saw the changes that you implemented. And then this is an example from Jelle van Kouwenberg from Ghent University, where they used manipulated photographs to investigate whether when they changed the streetscape, so for example added some trees or had a wider cycling lane or removed some cars, whether people were more likely to go and cycle to their friends and family. So I'd just like to conclude by saying there is a wealth of data and data sources available. And there is a lot, but don't just start gathering all this data and analyzing it all. First, have that idea about what you want from your urban environments, have that vision, and then try to categorize the determinants into tangible factors, and make sure that you choose the tools that are actually able to validly and reliably capture these measures. And don't forget that all these factors operate combined and not in isolation. So try to get a holistic view of your neighborhoods or cities or urban environments. And then for the next step, of course, we want to go from data analysis to action. We want to improve our urban environments. But sometimes it may be interesting to test some of the ideas that you have for improving your urban environments in virtual or small-scale settings. I'd just like to acknowledge my colleagues from the upstream team. We do a lot of this kind of research on environmental or upstream determinants of lifestyle behaviors and health. And I also want to thank you and the organizers for being here and enjoying this interesting session. Thank you very much.
Thank you, Dr. Mackenbach. So in view of the time, let me invite the second speaker. He's also an epidemiologist, but a public health physician. And he teaches, let me say, the health policy, public health, One Health approach, health promotion, and public health system, public health ethics, and global health. With such broad background, he'll bring us a context-based approach, context-driven approach to look at urban health. And he's coined the term healthy placemaking. Let's us learn about healthy placemaking. Professor Nadav Davidovitch.
Thank you very much. It's such a great pleasure to be here. I want to thank the organizers. It's been a wonderful conference till now. I'm especially happy to be in this session, and I think what I'm going to present will be very complementary to the previous presentation. So my main question today is going to be, if health in all policies is such a great idea, why implementation is so limited? And I know this is the main question that all of us are dealing with, and I want to present you some of our experience at Ben-Gurion University School of Public Health that I'm directing, and here to bring the notion of the healthy placemaking, and also to convince you that I want to introduce this term that actually one of my brilliant PhD students brought of the bureaucrat activist. So it sounds maybe like an oxymoron, but I really want to convince you today that we need more bureaucrat activists. Another thing that I want to present is also our approach. Of course, we have lots of processes, top-down, bottom-up. I want also to focus today about the middle out. Of course, we need all of this, but the middle out, I want to convince you today, and bureaucrat activists are really needed in order to move with health in all policies. So we all know this slide. It was presented here several times. And we also know that if health is finally determined not just by the ministries of health or the health sectors, so the solution that was brought to this was, of course, the health in all policies, the idea that we need to take a multi-sectoral approach, that we'll need to look for synergies and also improve population health and health equity. And I think that this kind of message was presented in many of the presentations until today. But of course, we know that many times we have these kind of silos. I was working at the Ministry of Health. I'm now at the academia. And believe me, everybody is talking about, breaking these silos, but the structure of the system and also the incentives are so much against it. I must say that sitting in promotion committees at the university, I can hear many times, this person is maybe doing too much, is working on too many different fields. So what's the problem here? Why it's not so decided? So how we need to bridge these kind of silos, and this was in academia, the same thing maybe can be said about ministries. So countries around the world, as we heard in the last 2 days, are working about intersectoral strategies, such as in the wonderful approach of health in all policies. But finally, we know from many different studies that implementation is limited, and we need to understand better why. And this is the main focus of my presentation today. And on top of it, we already showed by several of the presenters here at the left what drive the health outcomes, but we have also the paradox of prevention, that finally most of the money is spent by governments on medical services. And I want to add on top of that, that unfortunately, if you're going to do surveys, many times the public is also demanding more health services. And the question is how we're going to persuade better the public. So again, remember the bureaucrat activists. So what I'm going to present today is based on many different studies of our interests, how health in all policies is actually being implemented in Israel. We are doing mixed method studies, both qualitative and quantitative, using epidemiological data. And here I thank the previous presenter for showing all of the data sources. And I think it was interesting to see also her kind of mixed method. So I won't go to discuss the methodologies. I want to discuss more how it's being perceived by the different stakeholders, and what are the attitudes of decision makers, and finally, how we can strengthen health in all policies. So I want to take one of the very unfortunate case studies in Israel. Here you can see the Israeli map. I'm located in Beersheba. You can see here in the triangle, it's the whole half part of Israel is called the Negev, the south of Israel. It's mostly desert, very vibrant, very developing. And within the Negev, in this triangle, we have many different populations. One of them is the Bedouin population. It's an indigenous population of about 250,000, that about 1/3 of them are sitting in what is called unrecognized Bedouin villages. And you can see 60% of them are under the age of 17. Fertility rates now is about 6.1, used to be 11 up until 20 years ago. By the way, Israeli fertility rate, we heard about Taiwan, is about 3.1. When I was a child, we had about 3 million people population. When Israel was established, it was less than 1 million. Now we have 9 million. We're preparing for the Israeli health plan for 2048. We were commissioned to do so, our School of Public Health. And this is planned for 15 to 17 million. So you can see the amazing change. So talking about people and environment and places, of course, it's a big challenge. And here you can see the unrecognized villages, the lowest socioeconomic status in Israel. And just to take one of the indicators, a very important one, the infant mortality rates, about, unfortunately, 3-4 times more than the Jewish population. And this is one of the wicked problems, because Israel invested lots of energies to reduce infant mortality rates, but the focus was mainly very medicalized, with a very strong focus on congenital malformation. Of course, it's very important, but just think if you are living in such an environment, okay, what would be the chances for infant mortality rates? This is Wadi Nam, one of the unrecognized villages that we are working with, and they are surrounded by an electric facility and also an industrial site, the largest in Israel, that was moved in the 70s to the south with the idea that nobody is living there. And of course, this was not true. NIMBY, not in my backyard, so this was the kind of a NIMBY at that time in Israel. Now, we're doing lots of work with Wadi Nam and other unrecognized villages, and I think here also the question of trust is very important. How you can conduct different interventions when there is no trust. And this is one of our main challenges. So this is the map of the development of the Negev. And what we did, we developed a health impact assessment approach that is multicultural. We called different stakeholders, and it was a very lengthy process. And of course, not every Bedouin is representing all the Bedouin society. There are lots of differences there, different tribes. By the way, many of them are now also going to the university, becoming PhDs. There is a new Bedouin Arab Medical Association with more than 400 physicians that we are working with. So the question of representation, of course, is very interesting here. And the question that we dealt with them that was very interesting for the population was the question of zoning, how we can differentiate different zoning activities. We have here at the middle the industrial site on the left in pink, and also the other side, the electric facility. You can see here several epidemiological studies that our School of Public Health conducted about infant mortalities, congenital malformation, respiratory illnesses. And of course, there can be other issues such as the smell from the facilities. And finally, with all these ecological influence and with the whole health impact assessment process, it was quite clear that there were different ways of knowing. And now in the previous presentation, I think it was really nice to show that collecting data might be not just by experts, it can be also by the population itself. And I think it has a lot of advantages because then the population itself is being engaged and involved, and it also can set the different priorities. So we know now from sociology of science different terms such as situated knowledge, popular epidemiology, and finally the question how we can move all of this knowledge to the decision maker. And we created different mechanisms of decision making and different mechanisms of creating trust. And this was a very interesting and learning experience for us. I'm not going, of course, through all of this. This is a paper we published about a multicultural model for participation. And I think what is interesting here is how sometimes we have created wonderful tools but cannot be adapted to a specific context. So health impact assessment is an amazing tool, okay? But we need really to take into consideration a lot of structural issues in order to make it really multicultural, okay? So the question of how to form the team and the team's diversity, how to form the different committees and the steering committees, these were very important issues that we discovered while doing the work. So this was about health impact assessment that we conducted, and there are many other examples that we did. Now I want to talk to you, as I promised, about the bureaucrat activist. And I really like this term. And what is a bureaucrat activist? And this is, again, based on lots of participatory research, community-based participatory research, focus groups, etc. So we are talking about, first of all, people that know the system. They know how to work informally. They know how to find the way. You know, there is a Yiddish word, it's actually a Hebrew word, chutzpah. Maybe some of you knows it. It's kind of the Israeli way of doing things. Sometimes it's being perceived as a disadvantage. I think that when we discuss the positive deviance, I think maybe it's something a bit related. People that are committed to the cause, that can be angry but also optimistic. And also what was interesting in our studies that they created the network. So maybe some person from the Ministry of Health working on the middle level was creating a kind of angry network. I see that Trevor is nodding, creating a network with other people, kind of informal network in order to move things around and, you know, although being within the system, how to act as almost an NGO within the Ministry of Health. They know, for example, how, and this is very invaluable, they know how to pass the budget. They know how sometimes to utilize, you know, these things when by the end of November, they're telling you, we have such and such money, thousands of shekels or dollars, but you need to spend it in 2 weeks. And then you need to prepare a program, so this person knows how to do it. They can use sometimes NGOs in order to influence the government. So because they are within the government, maybe they cannot openly criticize the system, but they know how to do it sometimes through NGOs. I'm working also with Physicians for Human Rights, and many times we are dividing the work, and sometimes things that might be said by a certain NGO or might be said by another one. So this is a very interesting division of labor. They know how to write the summary of the meeting and go to the officials. They know how to solve problems informally. To give credit, that's something that we need to learn. Sometimes giving the credit, maybe even if you are critical about your peers, it's very good. It creates allies. And they know how to find the other bureaucrat activists to work together. So after presenting this kind of multicultural health impact assessment and the bureaucrat activists in a nutshell, I want to present our work that we're doing about healthy placemaking. Now, some people initially were very annoyed by healthy placemaking. They told us, healthy placemaking is about health promotion, so why you need to have these trendy words? And maybe I agree to that, but I think that sometimes reframing and changing the terminology can bring to the table people that maybe were left a bit outside. And at least with our experience with the healthy placemaking approach, that again, I totally think it's based on the classic, nice, health promotion ideas, or maybe even the sanitarians that were mentioned by Professor McKee yesterday. People that really understand that politics is a determinant of health. They understand the different social and ecological determinants of health. And they know how to connect people and places. So regarding the question in the previous panel, I do think, as Trevor was maybe suggesting, that we need both the people and the places in order to promote health and well-being. And are very creative. They know how to give attention both to the physical, cultural, and social identities. We had a visit in Philadelphia. Maybe some of you saw, there are more than 1,000 mural paintings there, where the communities were working for a long time to bring their own values to these mural paintings. That these were wonderful projects, so this is just one example. So you're bringing to the table city planners, artists, and it's something that is very different than the usual suspects, that are working together in health promotion. Again, I know that many of you are doing it anyway, but that's something that we discovered that just by creating this framework can be very, very useful. Of course, it's a system approach, interdisciplinaries, and the idea to reverse the direction where communities are taking responsibility. This doesn't mean that the government has no responsibility. Of course, the government has responsibility. Of course, we need to do the structural work in order to change the status quo, but we're giving also the power to the communities. And you can see here that the whole idea, and this was also mentioned here several times, that we know so much already about what needed to be done, but the question is how. So healthy placemaking can help us to create different design. It can help us bring the communities, and it can help us to change the built environment in order to have a great impact. Okay, so this is some of the definitions coming from the WHO and other organizations. Of course, we know about healthy settings, and healthy placemaking is also a part of it. And some of the key insights that we had for our work, that unfortunately many practitioners are not using the data that exists, and there's a lot of data, as was presented in the previous presentation, that is just there and many times unfortunately not being utilized, or sometimes because of the silos, some data is there and people even don't know that it exists, and they're creating again and again very expensive and lengthy data collection system while the data is already there. Also about public consultation, same things. Sometimes we have, because of the silos, different departments in the municipality collecting data about public, and unfortunately, because there is not enough collaboration, the data is not being used in a good way. And another interesting insight that I want to bring here, that people engage in healthy placemaking, many times they prioritize outdoor spaces, while we need to know, of course, that most of our life actually is indoor. So I think we need also to speak not just about the outdoor spaces, but also about the indoor, and how to create indoor spaces that are much healthier. In some of the discussion we heard in the conference about healthy aging, I think there were some very interesting examples about changing and reframing indoor spaces. And maybe one of the most important insights we have, actually, that we need to engage much more the local authorities. In Israel, unfortunately, because of historical reasons, things are very, very centralized. Because of previous decades, with lots of corruption in on the local authority level and inefficiencies, many things are centralized, and we need to give the local authorities that they know best, the citizens, they know the neighborhoods, the micro and the meso level, and healthy placemaking is a wonderful platform in order to change and work with the local authorities. So some other observation, and then I'll give you some details about innovative course we have already for the last 6 years. It is inter-faculty, and believe me, just talking about interdisciplinary work, just to convince the university that people from different faculties can enlist in the same course, this was a nightmare. Again, talking about structural changes. So some other observation we had in our studies, many times we need to be disruptive, because the formal mechanisms can achieve only partial success. The mid-level is very important. Sometimes the silos can be open there. And we need to work in a situation where, unfortunately, there's budget and government instability. In Israel, we don't have government already for almost 6 months. Unfortunately, Ebola, polio, lack of hospital beds are usually being mentioned as the most important priority. Now, I'm not trying to say that these are not important issues, but maybe some of you heard we had in 2014 a silent epidemic of polio with no clinical cases because we have very high vaccination rates. But because of the vaccination campaign, all mother and child healthcare centers, for example, drop-off milk stations, everything, all the resources were taken there, okay? So I wish that the same energies were directed to health promotion and the same resources, and this is again related to the question of the prevention paradox. So this is a paper we just submitted for publication, action from the middle out. Again, we need both top-down and bottom-up, but the middle actors, the mid-level, are very, very important, and here we need the bureaucrat activists. So we need to empower the social fields where silos are open to take the opportunity. We need to enhance activist symbolic power and create space for discussing struggle. And just to finish my presentation, this is the course we have at Ben-Gurion University. You can see here we have different partners, both on the municipality level and the regional level. We had many beautiful projects. I will maybe just mention one. We were working with Bedouin women to create walking path in Rahat. Rahat is the largest Bedouin city, a recognized city. And it was really fascinating because these women needed the approval of the religious people, and they wanted the path to be not too central in the city, but not too outside of the city. And we were training community leaders to do walking groups together with Bedouin women. And this was a very interesting experience, and it created lots of unintended good consequences. You can see here, this is Segev Shalom, another Bedouin village. Another great initiative is having children dancing with the elderly. So just think about dancing in terms of movement, memory. It's a wonderful experience. And just the last project that we are doing, this is Professor Jonathan Deutsch from Drexel University. He's a chef and also professor of culinary sciences. And we started to work on food waste together with healthy nutrition, both in prisons and schools. Now, if you know Foucault, maybe prisons and schools can be quite, not just Foucault, there can lots of many other comparisons. But we created an interdisciplinary group with anthropologists, nutritionists, and public health practitioners, of course, and also economists to see how we can do a win-win situation and have, for example, the inmates in the prison cooking themselves so they can both create a sense of a small community because they are dealing with the food and cooking together, and also reducing food waste, because before that, things like rice and other things were just thrown away. And just to finish up, go for the bureaucrat activists, work in a disruptive way, and also take a look about the healthy placemaking initiatives around the world. Thank you very much.
Thank you very much, Professor Nadav Davidovitch. I'd like to give a footnote here when Professor Chen is walking to that. I was really pleased to hear you in the middle of your presentation say, how do we facilitate health in all policy? That was highlighted in 2015, Helsinki. But I'd like to remind you, in 1986, precisely when Dr. Trevor Hancock and Landu, Professor Landu, they proposed Healthy City, the Mandela. That's exactly the same essence. Integrating health into all sector and giving the local authority, they played the big role in creating the future. So I'm glad that in 2019 now, we're working on urban health. We already predicted 30 years ago this would be the problem. And that we travel into the same place. We conclude that we must collaborate together, putting health on the agenda of cities. And that importantly, and I think that today's time, we are really working all effort, how do we bring everybody's wisdom together? And I think the last speaker may serve that purpose, because the big data today can serve us to do better planning and to inform us better. And maybe if we can actually work together, it can serve all sectors to be on the same page so we can work together. So with that, Dr. Chen, Tony, he'd like to be called Professor Tony Chen, the Vice Dean, College of Public Health, National Taiwan University, will inform us about how applying big data to urban health, and that he would like to consolidate a network of sensor data obtained from he will present to us that different dimension and how we can be better use of that.
Thank you so much for introduction. Of course, I think we need to work together. First of all, I still thank for Ministry of Health, particular the Health Promotion Administration, Dr. Wang, invited me to give a very challenging speech. This is very challenging, as you can see. So I think I'm trying to deliver a speech is to show how to apply the big data, but combine with our traditional health data. Because I come from a traditional public health training, although I'm a dentist, from undergraduate, but I love public health so much, and even global health right now. So that's why I think this is a very good chance of just the previous speaker saying the silo data. So how can we combine the current big data and also our health data together to make the city become smart? So the topic actually today, I want to tell you, we could be a very smart cities, but this is not easy job. Okay, so my topicals can be simplified into the 3 sections. One is, of course, we go back to the real data to see the life expectancy and urbanizations. Then I show you during these 20 years how the AI have been applied to, the big data, how can apply to improve, our health and also our city become very, very smart. And the final one, I think I want to emphasize how to combine this data. And I show you examples because I get involved in the community-based health intervention for 20 years. So I have a chance of collaborating both sides of the data together. So this is actually my talk. So as you can see, the percentage of world populations is projected, by WHO to increase from 54 to 60 and until 2/3 until 2050s become, the urban cities. And despite most of the growth happen in the low and the middle income countries, but I tell you, even in the high economically developed countries, they still have very heterogeneous, aspect. So that's why we need goal and the guideline. That's why in any global health forums, including Taiwanese global health forums, I attend so many in WHO, in Geneva, in Germany, in M8. So our previous, the director, Su Tiqiu, also, make very contributions to this site. And you can see, we need the multi-aspect. We need to multi-stage. We need to multi-sectors to cooperate with each other to improve from poverty until partnership. And during this process, you can see you have to take care of health. You have to take care of the sexual inequity and also inequity for everything, and also for climate change, and also for justice, everything. So this is a very complex system. And this is a challenge. And the goal actually is want to the city become a smart cities. So that's why we now understand why WHO is so ambitious to provide such kind of goal. Then, go back to the real world data. People ask me, I want to live in the rural area rather than the urban area, because that's the definition. Forgive me, it's not always you propose. I just play a joke, because students say, oh, I want to go to the rural because they are very peaceful and they are very silent, serene. But look at this. Everyone is familiar with this purple chart. Wealth and health go hand by hand. But you see, I always inspire my students with one thing is, although we know this relationship, but one thing is very particular. If you look at the variations, in the high economic development and the low and middle development, there are more variation in the left compared with the right. So we call this is a health disparities, you see. So this is a very important concept. So the smart city actually want to reduce this. I mean, of course, this is also my public health goal, you know. And how about if you change the GDP into the urbanizations, then we take the data. I mean, this is one kind of data. You can always convince your decision makers why you need to do, you know, the highly developed urbanization. Because you can see this is exactly the same, the health and the wealth bubble chart. So you see, that's why we need the urban cities. But during the urbanization, you need very smart. So you can also see, in terms of the prematurities, the left side, still a lot of the area, you know, they die from before age 70s, you know. But the right side gets very few. So this is so illustrative and illuminating to tell us we still have a lot of long way to go. So my job has to identify why we have such kind of the disparity here. So that's why you can see, first of all, in the societies, if you are sick, you always want to have a universal health care. I mean, this is happening in Taiwan. That's why Taiwan is so good for national health insurance. Because even the dental care, that's why I introduced, my background is dentist. I always use the dental care as example in the world. Taiwan is very famous with a very high density of dental care. If you walk on the street, you can see so many dental clinics you can look for and to pay a visit, and also pay by national health insurance. So this is not, you know, like the slum area. You know, this is very, very dense, you know, the area to provide the care. So what they help, because if you remember, I indicated the two countries in the life expectancy plot before. The universal health care account for why they have a same GDP, they have a same urbanization, but the life expectancy is different. Why? Because the universal health care scores is different between them. So you can see WHO already used the data from World Health Bank to cover infectious disease, NCD, and also basic maternal care, and also the capacity of the service. So this is very important. So that's why people doing the job with the data need to help the decision makers to identify. And of course, in addition to healthcare service, we have to talk back to the basic needs. So that's why there are so many ongoing the project for such kind of the smart cities to reduce the slums, the project. And I don't need to say that because you know very well. And also the transportation, air pollution, and traffic, and low safety. But I want you to think one sense. In urban societies, I mean, as I know, you know, as you know, every day, every morning, you need a coffee, okay? You need a coffee. I need a coffee. I'm actually an alcoholic coffee. Yeah, I mean, I drink too much coffee, but I try to reduce. But, you know, coffee. But why people love coffee? So now we need evidence. We need evidence. We cannot talk only drink coffee. From smart cities, people will ask you, what is beneficial to drinking coffees? And because I have a community data, I collect the data held by health promotion administrations. So I demonstrate to you. This is unpublished data, but we analyze many times in different Taiwan cities and adjust so many factors. You can see coffee can lengthen your life expectancy by 2 years. This is data, empirical data. I know maybe still have some selection bias there, but I make adjustment as much as we could. 2 years. So that's why we don't talk about always, the detrimental risk factors. We have to talk about the protective factors in order to create a smart city. So this is, but of course, I'm a public health, traditional public health. I need to go back to the realities. I mean, the first speakers and also talking about obesity. I mean, I know this is also very severe problem in the urban city, but not only for that. How about alcohol drinking, smoking? Still, although Taiwan has a very, very good evolution about smoking regulation. You heard that before, and this is actually also show the life expectancy are affected by this bad habit. So I did some health promotion programs. I did some the interventions. So I project this is a life expectancies, improvement due to the such kind of the lifestyle modifications. And I always use this to support our decision makers. If you want to, budget properly, privatize your resource allocation, you can use that. So this is actually my first part about using the data, including I call the health data, including the sensor, survey, census, administration data, biobank data, and so on. But is this enough? I think it's still limitations. So that's why, you see, we need the big data. The big data actually depends on how much sensor information, as the previous two speakers also emphasized. And today, because you have an IoT technique, so you can always use many sources of the data to become very smart. So my concept to use the big data is to tell the people, you have the much thought about integrate various kind of the source of data. As a second speaker say, we cannot silo, we have to share the data. And of course, for the health data, this is very important because the AI is very useful for precision medicine, as everybody knows that. I also get involved in these areas as well. So I show you how to use both of data together to create some assumption which render the smart city come true. But before that, I just give you very, very brief review about the technical, because these technicals is so important. People always misunderstanding about the traditional approach and also the AI approach. So I want to say something about difference, and I want to say something about what their purpose. So big data machine learning has been widely used in geoscience, no doubt. If you turn on page about Nature and Science papers, there's a lot of the applications, publish these papers. So the left side is a tradition, the right side is the AI. The AI, because in the traditional, I'm also a biostatistician. I always challenge my students, why we need this regression model, why we need the Cox regression model. Can we do other things? Can we do other models? So the traditional models has a powerful, the powerful function, but they have a limitation because they have a predetermined, pre-selected models. Then the AI can identify the unexplored hypothesis, which can be used to improve, your life, your health, and so on. So this is one thing we have to analyze. And this is just show the AI want to use the different kind of technicals. And they are actually, because people always criticize AI is like the black box, but actually they are not, you know. They do have from the data training and the simulation and different scenario, and they have then they have a result and they have a validations. So this is actually a procedures, just because they don't have time. Because if you give a speech 25 minutes, you cannot have a time to talk about detailed technical. So everyone, you know, think about this is not. And AI has a two main functions. One is prediction on the left side. One is the discovery of the new classification taxonomy. You know, so they have a different purpose. They have a different. So people sometimes think AI always do the prediction. Actually, not quite. AI do the prediction because AI wants to predict. Because if you can predict, you can control, you can govern the things you want. So this is actually the AI, you know, provide. So I give you several very quick examples talking about not only in health. So this is a very interesting topicals about the urban heat island. And the urban heat islands already been discussed many years, but the reason is not very clear. So these papers use the AI technicals to explain why the urban and rural, you know, the difference, the temperature, the surface temperatures is caused by population size and also precipitations. So the engineer can make better use of the energy and also to use the green cover policies and also to use the very good habitable policies to improve this situation, particularly in the dry regions. But for the tropical regions, it still remains a challenge, you know, in the futures. And I mean, I also done some about climate change and health. This is a papers to talk about using our national health insurance data and to investigate the climate when the temperature lowers, our ability to admission emergency patient increase. So this is actually the quite similar. So this is one kind of the things to use the geoscience data to support, you know, the health. And of course, the AI right now, you know, is living in the urban area, you know, you are afraid. The day before yesterday or someday, you know, urban, when earthquake come, you always, you know, very scared. Now you have AI to help you, to alert you, and particular aftershock. And this is just show the three area, including our Chichi earthquake, to locate after earthquake what is possible and what is likely to happen again. So this is actually quite useful for the AI to help you. And also, in urban cities, people with speech problem, I know in long-term care right now, they have so many problems like this. So the AI read your mind and recreate your speech functions. So you can speak like the normal people. So this is actually very interesting. And the final examples, this is just published also in a science article. They suggest if we can have an exosuit, the exosuit can help you to extend your hip. Then when you walk and you jog, then you can reduce your metabolic rate. You know, human is very, very interesting. The activity for human is very interesting. You know, in a slow, if you are slow rate, you can see the metabolic rate. You know, running is higher than the walking. But in the in the high speed rate, the other way around, you know, of these things. So they denied such kind of the exosuit. You see, to the upper part, you can see if you wear this, you can reduce the readout in the low panels by 9% and 4% in terms of walking and jogging. And this is the urban cities, they need that, you know. So this is actually to suggest, you know, you can always use very smart device to improve such kind. And because you have a device, so how can you combine the two as a whole? I give you examples. And the first examples I use my health data to improve the health care for some disease. Of course, you need data. So this is just show the community data I collect and with help of the government for 20 years. So we have longitudinal follow-up data to have a record about such kind of documented data. So you can see this is, because of that, we can create personal risk assessment models by different risk, as you can see the x-axis. And then we can suggest the woman, you know, to have a different, you know, kind of the prevention and also screening tools, and suggest a different strategy for using the imaging technique in order to make the cost very efficient, you know. So this is actually the breast cancer right now also we wanted to analyze. And we also combine the PM 2.5 from the GEO data and to link with the colon cancers. And we find actually PM 2.5 not only play in the initial low, but also it's a promoters. And also they can increase the inflammation process at the beginning because the fat concentrations is higher in people living in the PM 2.5 as well. And this is a very good example to show how to combine the ecological the informations to put in the visual outcome and to project, you know, the health risk assessment. So for the health data, actually, not only in the global disease burdens, but we can have a data to do some personalized risk assessment model. Then we can combine the two data set to do. And I show you two examples. One is hypertension. Again, hypertension, we can use data to build up the personalized. Like you can see, you can build up risk score to predict the risk. And you have a different kind of the curve to, yeah, this is just show different, yeah, okay. This is just show different curve about the different state of the hypertension for personalized. Then, in the long-term care right now, we suggest, you know, if we have an IoT device like this, then you can always, you know, use these technicals to combine the information to take care of the hypertension. And of course, that's why you need an AI technique to support the computations in order to speed your calculations. And show you another very interesting example is Parkinson's disease. This is likely to combine the personal the data by using the survey data to understand the severity of the Parkinson's disease. And if you have Parkinson's disease, in long-term care, if you don't have a capacity to take care of these elderly people, and you can analyze their data to understand their disease situations, like the natural cause you can see. Then you can make use of the device, wearable technology, combined with the mobile or the computer through the internet, and put on the cloud, and to alert the clinician and also caregivers. Then finally, we can do some evaluation to see how they can improve the mortality reduction and also the Parkinson's disease reduction, severe advanced disease reductions. And also, We can also use the AI combined with our informations to help the long-term care peoples by using the robot. And everybody know we have so many kind of robot from cognitive function until the social function and everything. So this is actually the robot, made in Japan. Although now it's still very expensive, but the other people like it. They love it because they can have not feel very alone, and they can also use as mental health therapy as well. They can use as a mental health therapy to improve their depression status as well. So it's going to be very interesting to see how to combine the two data sets as a whole and to reach. This is the final slide I just want to share with you. It's a challenging and it's a future job I want to do. So the left side actually is personal risk assessment models. And by combining the IoT in the futures to reach, the goal until global health. And the right side actually is to combine the informations to make the different policy recommendations from environmental science, community intervention, and also healthcare policies. So this is very ambitious, I know, but this is why I think we are here to talking about how to apply the big data to urban city. And thank you so much for your attention. Thank you.
Thank you, Professor Chen. Well, he showed us the brave new future. I hope that your next task, too, even more brave and more important, is how to safeguard that decision-making lies with human, with the collaborative, passionate, value-based human group, than humans subservient to the AI. That will be your next challenge. Now, I get bad news and I get good news. The bad news is we will no longer have question and answer discussion that invite your input. The good news is, particular for the coffee drinker, the coffee is ready, the food is ready, they're waiting for you. Thank you.
Very much to our moderator. Thank you so much, ladies and gentlemen. We're breaking for lunch. Please come back at 1:30. And 麻烦请记得归还同步口译的耳机. Please return your simultaneous interpretation headsets. Lunch, same as yesterday. You need your badge to go for lunch, 3rd floor. However, ladies and gentlemen, 如果您参加的是101的下午分场的会议，您就可以不用还耳机 okay? If you're coming back to the parallel session at this room, that's a special scenario. You do not need to return your simultaneous interpretation headsets. But if you're going for the parallel session in other rooms, please return the simultaneous interpretation headsets. Thank you. Lunch is at 3rd floor, the same banquet hall that we had lunch yesterday. Enjoy your lunch. Please come back at 1:30 into your respective parallel session rooms. 如果您下午参加的会议不是在101，就麻烦拜托需要归还同步口译的耳机。Thank you so much. This afternoon, room 103, room 102, room 101, room 201 AF, and room 201 BCDE. And please be reminded, we have a closing ceremony today at 5:50. After your parallel sessions, please come back to this room for the 5:50 p.m. closing ceremony. 下午分场之后，在5:50，也麻烦请回到101 有闭幕仪式，谢谢大家 ，Thank you. Oh, by the way, now the stage is open for you to take photos. If you have friends, groups, the stage is now yours for you to take photo, because this is your lunchtime.